I think the intent here is not for me to be presenting a lot of data, but really to be level setting a little bit with a few slides to generate some discussion around the use and improving access to CAR T-cell therapy. I think we know that in general, if you look certainly at the United States, of the people that are eligible for transplant, only 30% are actually referred for transplant. I suspect the percentages for CAR Ts are even lower. And we're gonna see some data that speaks to some of the disparities in terms of referral and access. So as you know, we've got two approved CAR T cells. We've got anito-cel that is in phase 3 trials, and we hope this will be a third compound for us as well, all targeting BCMA. We also have the arlo-cel compound that is in phase 3 trials as well, targeting GPRC5D. We hope to have another CAR T-cell coming. And then there are a mix of auto and allo products. And we're going to briefly talk about both auto and allo products in terms of the pros and cons. But this is sort of a little bit of the landscape in terms of what's there. And I think what all of us are impressed by is the response rates that you can see on the right side. What I think all of us are not quite as happy about is where the plateaus on those curves look like, given the experiences patients have to go through to get a CAR T cell. So I think improving is certainly an important part of the process, and that's why we have so many different versions and flavors of CAR T cells in the development now. So I think you all know this pretty well, so I'm not gonna belabor this. Obviously, there's an auto and an allo CAR T cell. This is the process in general for an auto CAR T cell. And then this is sort of the treatment pathway. And again, I'd be interested for our colleagues in Europe to sort of give their spin on this, because this is some of what happens in a US-based approach where most of the patients are taken care of in a community center. And so the identification of a potential patient for CAR T often needs to happen in the community. And they need to refer into a CAR T cell center. I think many of us that have really large programs, we feed our own CAR T cell programs through our own patient volume. But a lot of centers are dependent on those referrals, and those referrals are often, at least in my mind, the weak link. And again, we can, during the discussion, have some of our European colleagues weigh in a little bit here. So in terms of barriers, again, in the US, obviously the two big ones are referral, coordination, and then insurance. And so I think those are big pieces that often limit the ability to deliver a CAR T cell. And those are potentially addressable and can be overcome, but they require a fair amount of awareness and education, as is listed at the bottom. Next slide. So in terms of barriers to CAR T cell, this is a retrospective analysis of about 250 oncologists who looked at what are the barriers to referring or using CAR T cells. And as you can see on the left, from the treating center perspective, the number of slots allocated per month. I suspect that that's old data, because I don't think any of us have limitations on slots in 2025 in the US anymore. So I think that's a little bit dated. On the right, you can see financial burden, relocation, and toxicity concerns. Those are the things that oftentimes patients bring up. I think patients, at least in my experience, are sort of twofold. There's the one that's scared of a CAR T cell, and then there's the other one that wants to talk about a CAR T cell in the context of MGUS. So you've got extremes of what patients know, read, and what they want to expose themselves to. And this, again, looks at populations in terms of access to CAR T cells. And you can see that there are certainly a number of patient populations who don't have what's thought to be good access in terms of CAR T cell. And that really is of greatest proportion in the Black or African American patient population, and to a certain extent in the Native Hawaiian or other Pacific Islander. I would imagine the Hawaiian is probably an issue, mostly because there isn't really, I don't think there's a CAR T center in Hawaii, so they have to come to the US, but usually to California to get that, which again is a travel barrier. And certainly our center and others have demonstrated that if you are a Black patient with myeloma and you are treated at a tertiary referral center, your access improves, and quite honestly, your outcomes are significantly better. Your survival mimics that of non-African American patients if you are if you have access to a major myeloma center. So I think those referrals are important in a number of different settings. What about manufacturing and attrition? I'd be curious again. I know I can see Morie here, but I know there are others on this, whether or not there are significant issues with attrition now. I think that was a problem before where we were in fifth line therapy and bridging was not as good as it is now that we're using earlier lines of therapy. And we typically know what we're going to use to bridge, and most patients will refer to bridging. So I think that 14% in CARTITUDE-1 is probably a little bit high for my personal experience. But again, I think this is a discussion point we can talk about as well. I also think manufacturing is more streamlined now than it was probably when this data was collected. In many cases, the CAR can be ready within 28 days, and given a 2-week washout before infusion, that really doesn't give you a lot of time for bridging. And so I think the disease burden often drives when you give the CAR, not just the manufacturing and the attrition. So what about solutions and recommendations? Again, these are some of the things that I know people are working on. And I think all of us would agree that if you're a center that is dependent on referrals, please send the patient earlier rather than later so we can plan through what that would look like, do some initial insurance clearances and get the decks cleared for that patient to be within the setup. I think while we can debate whether first relapse is the space many people are using CAR-Ts now, I think most of us would agree if you've got a functional high-risk patient that, at least in our center, relapses within 4 years of their diagnosis. That is somebody that we consider for early CAR-T because outcomes with traditional therapies are somewhat limited. Again, these are just what people do in terms of trying to optimize. I think the key here is having agents that you can use to get disease burden under control prior to proceeding with the CAR. And the later you wait, the fewer agents you have, the more toxicity those agents are associated with, and the lower likelihood that you're going to have a patient complete the process. I think LD chemo is relatively straightforward, and I don't think is a major issue for most patients. So again, I think the keys are to potentially provide access to suitable patients earlier. These are a couple of bullet points, referrals, reasons for doing this. And I don't think anybody on this group is going to disagree with most of what's here, but I think these are sort of many of the messages we're trying to send, at least in the US, so that patients get sent into the referral center sooner rather than later. So the idea of accelerated manufacturing obviously is very attractive. Conventional manufacturing is at least 1 to 2 weeks of ex vivo manipulation. We did have, for instance, a product that was able to be produced within 72 hours, but unfortunately that product was pulled. There are other fast CAR products that are in early development that, again, are relatively quick, where once you make the decision to go, you can apheresis and likely infuse within 7 to 10 days. That would certainly help us in a number of ways. But if a patient has florid relapse, you're still going to need to bridge to get disease control, I think. I think all of us still want to know that patients are sensitive going into a CAR to try and maximize their long-term outcomes. The allogeneic CAR, there certainly are a number of products in that slide set that I showed you earlier. I think the allo CAR has the upside of fitter T cells off the shelf being ready to go relatively quickly. In my mind, the downside of the allo CAR is that the half-life is very short, and we know that one of the reasons why the cure fraction may not be as high in myeloma as it is in lymphoma is because the persistence of the product is shorter in myeloma than it is in lymphoma. And so I think, at least in my mind, the long-term outcomes with allo CARs are probably less interesting in myeloma, but certainly, again, a topic for discussion in just a moment. So on the next slide, we've got a couple of points here, and why don't we revisit one of the points that I wanted our European colleagues to weigh in on here, which is the process of referral in Europe. And then Morie, you can talk a little bit about this from the US perspective, and then we'll go through these 5 questions with, again, a group discussion. So any of our European colleagues, if you want to talk about the access and process for referral, that would be great.
Yeah, unfortunately for Italy, we are one step backward, Sagar, because our access to CAR-T is not there yet. We still just have ide-cel in 4th line plus. So to answer to all those questions together, the process is doing well because, of course, with ide-cel 4th line plus, we don't have a pack of colleagues and patients who want to come to the hub center to receive CAR-T because, of course, the alternative is at least such good as. And so I can say that by now the process is working well in Italy. I mean, we don't have issues with education, with referral and so on. The big issue for us is that we are waiting cilta-cel reimbursement very, very soon. The big issue will be that given 100 the patients who deserve a CAR-T in 2nd line, I think that we will be able to provide to less than 1/3 of them because at least in the public system, which is 80% of the system. We do have some private hospital, but they are very, very few, just in Milan and in Rome. With the public system, we have a limited number of CAR-T per month that we can, per year, sorry, that we can give to the patient. So, for example, in my region, last year, it was no more than 12. That, of course, with ide-cel, it's fine, but then the day it will be cilta-cel, it will be a different story. So we will be pushed to make a sort of a priority choice in 2nd line. And I absolutely agree with you that functional high risk are for sure my first choice. But then that's not optimal because, of course, a standard risk patient could benefit a lot of cilta-cel 2nd line. So I think this will be the biggest issue at the beginning for the first years, at least in Italy. So to make a priority of who is mostly benefiting of cilta-cel 2nd and 3rd line. And I fear that we will make a selection bias of worst patient because maybe the ones who are more aggressive, we are maybe dedicating more to them. So this is for sure the first point in Italy.
Thanks, Elena. Sonia, did you want to make a comment or should we go to more?
In the Netherlands, currently, we don't have cilta-cel and ide-cel available. But what we do have is access to CAR-T cell therapy for lymphoma. And what we initiated in the Netherlands, that's a national CAR-T cell tumor board. So every hospital can participate in that. So every patient will be discussed there. And there will be a judgment by the CAR-T cell tumor board whether the patient is eligible for CAR-T cells, and then the referral will be there. And by doing that, we have just the same results as in the clinical trials. So it's a very well-organized board. And now we initiated that also for multiple myeloma. We started because we hope that we will have access soon. It's still in the lock, so the negotiations are there between the health insurances and the companies. And that works very well because all the hospitals in the Netherlands, so whenever they have a patient, they can discuss the patient in that tumor board. It takes a lot of time. It's a small country, I know, but it works very well.
Thanks. Morie, do you want to talk a little bit about the process?
Sure. I would have to say that the unspoken and educational gap relates to out-of-pocket expenses for the patient. So when I see patients, usually the discussion is what type of T-cell redirecting therapy will it be, bispecific or CAR-T? And whether the patient is explicit about it or not, oftentimes CAR-T means relocation to a center like ours for a month. And a month of hotel and a month of lodging and a month of meals for some people is a big determinant between bispecific at home after the ramp up or CAR-T. And so, quite frankly, both for commercial and investigational products, being quite specific with patients about we're going to cover your lodging or we're going to give you a stipend for meals is a really important thing because people don't always want to say, well, I haven't got $4,000 or $5,000 to stay in Rochester, Minnesota for a month and make multiple trips for collection and then back for lymphodepletion, and then maybe late complications. And so it's financial barriers that I see since we have all the approvals, and those financial barriers, maybe Medicare covers the agent and the supportive care, but it's not going to cover the fact that I have to move away from home. And so being very specific, whether it's cilta-cel or investigational drugs, about what the supporting pharmaceutical firm is providing in terms of support during the procedure, I think can be very helpful. And for us, when we relieve that financial barrier, because we tend to lean more towards CAR T than bispecifics, I think it helps the patients with the decision.
Thanks, Morie. Meral, I don't know if you want to add anything.
Yeah, and Sagar, that's totally different in Europe. In the Netherlands, there is no financial hurdle because here, of course, we have a healthcare system based on solidarity. So either we have it or we haven't it. So we have an issue with not having access at the moment because of the negotiations. But whenever it's out of the lock, everyone will have access to that. So it's merely communicating with all the healthcare professionals. But for that, we have a very good system.
Yeah. Yeah. So tell me about on both sides of the Atlantic collaborations. Morie, you referred to the housing needs, but even after they go back, they still need to be given care and recommendations. How does that work from your practice? And in Europe, I would imagine everybody doesn't stay in the big academic center. They go back home. Who helps manage them when they're closer to home?
For us, the biggest logistic issue is immunoglobulin replacement. Everybody is getting immunoglobulin replacement. And if you're in Hibbing, Minnesota or Bismarck, North Dakota, that's not that straightforward to arrange for that to occur. That would be, I would have to say, our main supportive care. We do a lot of our, for example, surveillance, for example, looking for EBV and CMV. We can do that with mail-in kits. So that isn't a problem, but there's some active administration. Sulfo-allergic patients need a pentamidine inhalation. Also, if you're in a rural area, those are very complex things to arrange. Even if you're allergic and you try to desensitize, well, you need an allergist to do that. And so there are some of these things after the fact during the monitoring that are issues if they live at a distance from the center.
Yeah, I think those are important, Morie. And, I will say I learned from, I think it's Dr. Usmani's center that actually gives IV pentamidine once a month instead of inhaled. And the efficacy is actually the same. So we've actually switched that, which is, it is an interesting challenge because most patients, even if they can take the inhaled, they don't want to take the inhaled because it's such an uncomfortable procedure to go through. Sonia and Elena, do you guys want to chime in here in terms of partnering with other docs?
Yeah, for us, Sagar, we live in a very, very small country with 7 academic hospitals. So the hospitals are quite nearby, and also patients are quite nearby. So at the moment, what we're doing is that the first half a year, patients are just within our hospital, not within, but they come to the outpatient clinic, and we provide all the care. But whenever it's necessary to have some care near at home, we have a consultancy system in the Netherlands, which is consisting of 7 regions, and we do the consultancies for all the regional hospitals. So, and we meet each other every week via Teams, so we can discuss all those patients. So that's very well organized, but also for patients, it's much more easy to come. And yeah, they come for the IVIG.
And Meral chimed in on the chat that they don't have cars in Turkey, but they refer patients to Germany, and there are a number of places, it looks like in Turkey, that are trying to establish local manufacturing. So the academic cars, like I think is happening in Europe as well. So go ahead.
No, sorry, regarding Italy, it's slightly different, both from US and the Netherlands. I think that the bispecific did most of the job because, well, in Italy, we have maybe less academic center, but many non-universitary but hematological centers. So we have many small centers that are really focused on myeloma despite not being academic. And the job that was done and is being done with bispecific for the infection is helping a lot also with CAR-T, because now they are all trained about infection, opportunistic infection, IG replacement, and so on. So for us, I told you that currently we have few access just to ide-cel, but for those patients, we received 30% of patients from out of the region. We manage them for the first months, and then we send them back to the initial hematology. Maybe they are not a CAR-T center, but they are a fully engaged and let's say advanced myeloma center, so they can manage perfectly. And honestly, we didn't have a single issue, never. We can speak with them, we are friends, we are knowing each other, and so on. So it's different in Italy because CAR-T centers are few because of the Italian rules, so they have to be certified by this European JC organization. But hematological center dedicated to myeloma are much, much more.
Yeah, and that Elena, it's the same in the Netherlands. So we have to have a JC accreditation. So that's why it's only in the 7 academic centers.
So let me ask you guys to comment on the sort of the last bullet point here, which is next generation or off-the-shelf CAR-T. And let's not focus so much about access yet. Let's really talk about what you would need. So we know, let's say you got access to both ide-cel and cilta-cel for whomever you would want. If you are trying to evaluate a new CAR product coming through, what are the factors you would use to decide whether or not you're going to use that new product versus ide-cel or cilta-cel that you already have in your pocket? So in other words, what do you want to see get better with the products that are coming down the road?
Yeah, well, low toxicity, if you are, this is enabling just to an early outpatient management, for sure it's a point. Very short recovery just to infuse the CAR-T and something else. If the management is getting easier, that's one point for sure.
Okay.
Yeah, Sagar, in addition, I think especially the toxicity. I mean, it's limited, of course, when you move in earlier lines, but still it's there. And so whenever you have a product which is not giving rise to that, that would be perfect. I think in the Netherlands probably it will also be costs. So whenever it's kind of equally effective, I mean, we will be reinforced and maybe even forced to give the product which is cheaper. So whenever you have off the shelf, but that will take a long time because then there need to be gene editing in order to prevent graft versus host and graft versus and graft failure. But whenever that will lead to less costs, to cheaper products, that will also play a role in the Netherlands. Well, efficacy, of course, it's hard to beat cilta-cel, but whenever still, I mean, you see the curve in the first year, you have when you use it in late line, of course, 25% of the patients having progression and death. So whenever you have a more efficacious product, that will also be nice, of course. Yeah.
So let me ask you guys about the allo opportunity. Do you all see a future for that in CAR? Is the time to manufacture important for you, or is efficacy more important?
Well, going into earlier lines, I think
me,
efficacy is more important.
Efficacy, you said, Sonia?
Yeah, I think efficacy is more important because now we're moving to earlier lines. So I mean,
Yeah.
then I mean that you have somewhat more time in order to get the cells. I think when off the shelf, of course, I mean, it will be much cheaper whenever you have a cell line creating CAR-Ts and will be able to gene edit with CRISPR and just produce your CAR-T cells. So that will probably be more helpful when you compare to the autologous CAR-T cells. And when you use it in later lines, of course, with the exhausted T cells, then you will have more a more effective drug, because like you see now, many patients already have been treated with a bispecific BCMA, so you will either have no BCMA expression or you will have exhausted T cells. So in that case, of course, yeah, it might be good to have allogeneic T cells.
Got
Yeah,
it.
but you
Got
don't
it.
have mutations having loss of your BCMA, of course, but when it's exhausted T cells playing the role.
All right. And Elena is weighing in. Efficacy is primary for her. Manufacturing time, not the major issues, particularly for moving earlier.
Yeah, same.
Okay. All right. Um, let's see. We've addressed a lot of this already, I think. And as I said, most of the.
Yeah.
Go ahead.
Yeah, I think, Saga, when you come to the education of the healthcare professionals, I think having access to the bispecifics, many of the doctors will treat with the bispecifics. And whenever it's either BCMA or GPRC5D, you will have less effect of your CAR T cells. So I think that's for educational purposes, that's very important to mention, so that you have your mutations with loss, so you don't have an effective CAR T cell possibility anymore, or your exhausted T cells. So I think that will be very important for introduction of CAR T cells also in the Netherlands.
Yeah, and I think to me it really comes down to how do you maximally use all the agents and the targets we have. So if you're able to give a CAR, it doesn't preclude from that same target being used in a bispecific later.
Yeah.
Whereas the reverse may not necessarily be the
Yeah.
case. So I
Yeah.
think that's a good point. That's a good point. But we are now seeing bispecific trials in first relapse. We're seeing bispecific maintenance. We're seeing bispecific as part of induction. So it's going to get very jumbled.
Yeah.
And I think understanding what is the BCMA expression, what are the mutation patterns when a patient is exposed to a CAR afterwards is going to be really important as well.
Yeah.
Yeah, to me, regarding this point, I would like to know more, because we know that just dosing soluble BCMA is not enough. So, okay, mutation, but well, not everyone is able to look for mutation worldwide in a routine practice. I mean, so I think this is a very important point, and I hope in the next year we will have some more to be translated for clinical practice, because, well, the trials, it's okay, but outside that, we need something fast, quick, available, and it's not clear to me if we are at that point or not.
Yeah, that's a good point. And I think what we are starting to have access to in the US now is targeted sequencing panels. So we use a panel called PlasmaSeq, which has 200 genes on it, and they include BCMA, and they include GPRC5D and FCRH5 and CD38. So we can understand, and we're going to stop doing FISH. So we're replacing FISH with this targeted sequencing panel that is commercially available. And we'll be able to know whether there are mutations or not. We had a really nice talk yesterday from Samir Parikh from Mount Sinai, who actually suggested that even in patients without mutations, that GPRC5D expression can be lost by hypomethylation, hypermethylation. And so you may miss that with a targeted sequencing panel. So I think it is going to get very, very complicated. But I suspect that the big centers, even in Europe, that you will start to move towards sequencing panels and eliminating FISH, and that might give you access to mutation data easier.